Good evening, dear doctors. I am Jagdish Joshi, Senior Vice President, Network Pharma Division. Welcome each one of you for this webinar, Early Diagnosis and Management of Hypertension. As we know, incidence of hypertension are increasing day by day, and early diagnosis play an important role in management of prevention of hypertension complications. We at Pharma Division present you Telmijuice, that's a brand of telmisartan, one of the most economical telmisartan. I am thankful to Dr. S.S. Lakshmanan, who will be sharing his vast experience and helping us with the practical highlights. With this, I hand over session to Dr. Amit Kamra. He will be moderator. He will introduce Dr. Lakshmanan as well. Over to Dr. Amit Kamra.
Thank you, Jagdish sir. On behalf of Macleods Pharmaceuticals, we all welcome you to this evening webinar on hypertension. And we hope that this webinar will be useful for the community physicians as well as the consulting physicians who are day in and day out treating hypertension. We have a very honorable speaker with us, Sir Dr. Sundaram Lakshmanan. Sir is the director of Priya Nursing Home, and he's the senior consultant in internal medicine and diabetology. He's the Stanley Silver Jubilee Gold Medalist for the best outgoing student in Doctor of Medicine exam. He's the chairman and also secretary of the Association of Physicians of India, Tamil Nadu chapter from the year 2010 to 2013. He's currently the scientific committee chairman of API, Chennai chapter, and secretary of the General Club of Chennai since 2001. Sir was the treasurer of API in 2002. Sir has organized multiple congresses, and to name a few includes TAPICON 2010, TAPICON 2017. Sir has been awarded Masters Teachers Award in the year 2003 for his teaching skills in the Postgraduate Forum of the API. Sir has been conferred with the Lifetime Achievement Award by the Tamil Nadu Dr. MGR Medical University in the year 2012. Sir is the recipient of multiple orations, and Sir was also conferred the Fellowship of Indian College of Physicians, that is FICP, in the year 2014. Sir has published multiple papers in renowned national as well as international journals. With this, I would like to hand over to Dr. Lakshmanan to take it forward. Thank you, sir.
Thank you, Dr. Amit. Thank you, the Macleod, for giving me this platform to share my experience in hypertension, the diagnosis and the management. My slides should be audible, visible now?
Yes, sir.
Okay. I think it's very important, as the Vice President said, the early diagnosis and management of hypertension to prevent the complications of hypertension. It's mostly underdiagnosed, undiagnosed, and though it's such a common condition affecting almost 1/3 of the population, even if it is diagnosed, it's either undertreated or untreated. People don't agree that they have hypertension. But treating hypertension saves from plenty of complications like ischemic heart disease, myocardial infarction, peripheral vascular disease, stroke, CKD, and the retinal complications. Look at the definition of hypertension. It is defined as a systolic blood pressure of 140 or more, or diastolic blood pressure of 90 and above. Any one is sufficient. There's no need to that both 140, 90 should be there. Or even you take a blood pressure medication, that means you are suffering from hypertension. But the guidelines now are changing. Now even more than 130/80 is considered as hypertension. Coming to the very important classification of hypertension, mostly we have the essential hypertension, which is 95%, which is no underlying cause. But we have the other 5 to 10% is the secondary hypertension, which has got the underlying cause. Imagine 35% of adults above the age of 18 suffer from hypertension in India, and most of which, over 90%, is essential or primary, and the secondary hypertension is almost about 5 to 10%. Don't miss secondary hypertension. That's a very important carryover message. This is what my probationary teacher taught me. A person looks red with hypertension is called essential. A person who appears very pale with hypertension is renal hypertension. That came the difference of primary and secondary hypertension. If you look at the causes of secondary hypertension, 80% is renal. And if you look at the parenchymatous lesions of the kidney, that's the main cause for the secondary hypertension. The acute glomerulonephritis, chronic glomerulonephritis, chronic pyelonephritis. Polycystic kidney is invariably missed. Normally, you treat a patient for hypertension for a number of years. Once in a way, the patient undergoes scanned kidneys. Then you know the patient has a polycystic kidney. So we call the adult polycystic kidney disease, the ADPKD. Coming to the vascular conditions of the kidney, the renal artery stenosis is both congenital and acquired. There again comes some of the causes for the secondary hypertension. The endocrine cause comes for about 10%. We have the adrenal, the primary aldosteronism, Cushing syndrome, the Pheochromocytoma. We'll talk about it a little later about what is primary aldosteronism and things like that. Acromegaly. Some of the people taking exogenous hormones like oral contraceptive pills, glucocorticoids for asthma, they also have secondary hypertension. Some of the endocrine disorders like hypo and hyperthyroidism, both can cause hypertension. We also have the hyperparathyroidism. By virtue of hypercalcemia, the patient develops hypertension. The other causes are the coarctation of aorta, the pregnancy-related hypertension, the pregnancy-induced hypertension, preeclampsia, and of course, one should not forget that the obese people have the sleep apnea syndrome. If you could correct the sleep apnea syndrome, the blood pressure disappears. So these are some of the causes where we have to tackle the secondary problems to treat the hypertension. I have a small mnemonics to remember for you. The A is the sleep apnea and the aldosteronism. B is the bad kidneys, the glomerulonephritis. And if you could hear the bruit, I think it's the best practice if you diagnose a patient with hypertension, please auscultate the abdomen for renal artery stenosis. You can classically hear the bruit. Look at the coarctation, you know the signs of coarctation, which has been taught to you in the undergraduate level. And the catecholaminé excess, the patients come with a severe hypertension, palpitation, sweating, but suddenly it becomes normal. Common in women, the pheochromocytoma, the classical features of Cushing syndrome. Some of the people take a lot of salt, they diet, the salt sensitive people, they develop hypertension. Illicit drugs like your cocaine, the methamphetamine, all can cause hypertension. Herbal supplements for reducing weight can cause hypertension. And endocrine conditions, as I told you, hypothyroidism, hyperparathyroidism, and you take erythropoietin injections, they also can cause hypertension. When we come to the primary hypertension, this is the main focus of talk today. There are several guidelines, so confusing, all with varying targets, 140/80, 140/85, 140/90, 130/80. And we do not know what exactly to follow in our practice. I have selected two good guidelines for you to follow. This is a guidelines, the JNC 8, which came in 2014, which says the normal blood pressure is less than 120/80, less than 80 diastolic. Pre-hypertension, it says 120 to 139 systolic and 80 to 89 diastolic is called pre-hypertension. Stage 1 hypertension, 140 to 159 systolic and 90 to 99 diastolic is the stage 1, and stage 2 above 160 systolic and above 100 or equal to 100 diastolic. This is the classification was followed for a number of years, and now the classification by the ACC/AHA 2017. Now the ACC/AHA also came with the updated guidelines in 2020. The normal remains constant, less than 120/80 is the constant blood pressure. That's similar to the previous classification. But look at the elevated blood pressure. Somebody has got a blood pressure 120 to 129 systolic and less than 80, they are called as elevated blood pressure. And stage 1 hypertension is the systolic of 130/139 and 80 to 89, it's called stage 1. That means somebody has got blood pressure equal or more than 130 by 80, they are called as stage 1 hypertension. So stage 2 is 140 systolic and above, and 90 diastolic and above. So simple, 130 by 80 is stage 1, 140 by 90 is stage 2. I think now the guidelines becoming stricter, stringier to target the blood pressure levels so that the patients do not go for end organ damage. Now there's another entity called isolated systolic hypertension, which is defined as a systolic blood pressure of more than 140 and diastolic less than 90. It is actually seen in people who are elderly, very common in your practice. People come with 160 by 70, 180 by 70. You may not know how to treat these patients. Very, very difficult. Elderly guys come with the isolated systolic hypertension. It carries a very, very bad prognosis, very adverse event on the, especially on the brain. They are the people who grown for the strokes. Now, who are at the risk of hypertension? As I already told you, more than 1/3 of the population is at the risk of hypertension. See, if you look at the numbers, I tell you the numbers, 35% is the overall population, but the age advances. Suppose the patient becomes, say, 50% becomes hypertensive. At the age of 60% becomes hypertensive. At the age of 70% become hypertensive. As the age advances, the percentage increases. The overall percentage of 35 is for adults above the age of 18 to above. Now, these are the risk factors. As I told you, the advancing age is a big risk factor, predisposing factor. All diabetics, mostly they develop hypertension. Men and the post-menopausal women, again, develop hypertension. If there is a family history of cardiovascular disease, and if there is a sedentary lifestyle, you are prone to get hypertension. Smoking, high cholesterol diet, low fruits consumption, very important. I think if you could read the Inter-Heart study done by Dr. Salim Yusuf, you would have given as one of the caution for the coronary artery disease, the low fruit consumption, obesity and weight gain, coexisting dyslipidemia, and people who take excess of alcohol, binge drinking. I think we have to avoid taking alcohol in a large amount, binge. You keep taking alcohol, your blood pressure shoots up. Next time somebody consumes a lot of alcohol, you please check your pulse rate. You can see that your pulse bounds up and you can see your BP is going up. Now, these are the cousins, diabetes and hypertension. See, 40 to 80% of diabetics, they become hypertensive, and diabetics 2 times likely to develop hypertension. Look at the complications, the peripheral vascular complications, the stroke complication, the cardiovascular complications, the renal and the retinal complications, all becomes 3 to 4 times more higher when you have a combination of both diabetes and hypertension. Now, the incidence in India, as I told you, 35% of the urban population have hypertension, 20% of the rural population suffer from hypertension. Very important story is that 70% of all hypertensive patients are now in stage 2, because now we follow the latest guidelines. BP of 140 by 90 and above is considered stage 2. So in a stage 2 hypertension, we always have to use 2 drugs in the armamentarium treatment. So monotherapy is slowly going out of the market. We are now using more and more the drugs together in the treatment of hypertension. And almost 12% of the hypertensive patients have isolated systolic hypertension. Now, the diagnosis of hypertension, what is there, sir? You check the blood pressure, you know, he's got BP or no BP. It's not so. BP measurement, a great person, Norman Kaplan, he's an authority in the hypertension. What he says, the measurement of blood pressure is the clinical importance that is performed in the most sloppiest manner. He's not talking about the Indian physicians. He's talking about the physicians everywhere in the world. We have no time. We consult the patient, ask the questions here, there. Little time, we take the blood pressure. So the blood pressure measurement is always very, very, very not correct, accurate. See, the patient has to be seated quietly, at least for 5 minutes in a chair, with the feet on the floor, not crossed, and the arm supported at the heart level and with a back support. This is called the sprint measurement. We had a beautiful trial called sprint trial. If you have time, you can go to the sprint trial and see how they measure the blood pressure in the sprint trial. The sprint trial is the one which has set the lower goals even for the elderly hypertensives. And you see the appropriate cuff size. The cuff bladder encircling the arm at least 80%. So when you buy a BP apparatus, you must at least get 4 different types of the BP cuffs. Bigger, much bigger, and the usual routine variety, and the one for the infants you must buy. And at least you have to take 2 measurements in 10 minutes interval. Very important, so that we know the patient is having blood pressure which has been recorded correctly or not. Please don't use mercury BP apparatus. It is thrown out everywhere in the world. I still see some of the practitioners using mercury BP apparatus. Please don't use it. Only digital validated BP apparatus. Just use the oscillometric, the automated BP apparatus. They are very, very good. When you buy 4 different cups to suit your patient's arm. You can also use this the time-tested aneroid apparatus, but the better way is the one which is validated automated BP apparatus. It's not very expensive nowadays. I think the prices come down. Everybody can afford to use it. Now we have the automated apparatus which checks the blood pressure 3 times with the interval of 1 minute to 1 minute each, and gives the value of the reading. It gives a really accurate blood pressure measurement. So measuring the blood pressure in your clinic is an utmost importance. Despite that, there's a difficulty in establishing hypertension because it's an entity called white coat hypertension. Some people, when you look at the doctor, nurses, the BP shoots up. So the BP will be 210 by 100, 180 by 90. But the minute they go out of the office, when they go home, when they go to their work spot, the BP comes down. That's called the white coat hypertension. And there's another entity called masked hypertension. It's the reverse of white coat. Patient will have a normal blood pressure, seeing a doctor. He's comfortable. When he goes home or to his office, the blood pressure goes up. So these 2 conditions are very difficult to establish by office measurement, and hypertension associated with the autonomic neuropathy in the elderly. See, some of the doctors will ask me a question. Sir, my patient's blood pressure, when he's lying down, is 200 by 80. When he sits up, the BP comes down by 90 by 70. So that's a problem with the elderly guys, especially diabetic guys, the cardiac autonomous neuropathy guys, where the blood pressure just oscillates between very high to the lower levels. And one cannot judge the blood pressure behavior in the night. Please remember, this is very important in your practice. The BP should dip down from the daytime blood pressure in the night, which we can never measure it by the clinic blood pressure measurement. So we have the other 2 things options. One is the home blood pressure monitoring, and other one is called the ambulatory blood pressure monitoring. Now, come to the home blood pressure monitoring. Ask the patient to buy a blood pressure apparatus of his own. You teach him how to measure the blood pressure at the house, because it gives you information. He notes down the blood pressure. You are given up medications. The response to the antihypertensive therapy, he knows by measuring his blood pressure. And you know how he is adherent to the therapy, the doctor knows. You also rule out the white coat effect, because when the patient measures blood pressure of himself, the white coat effect is gone. Sir, my BP in my house is only 130 by 80. Only when I look at you, the BP goes up. That's a very classical explanation of white coat hypertension. The home blood pressure of 135 by 85 above is considered as hypertensive when you take a goal of 140 by 80. I'll tell you later the graphs of clinic, home, and ABPM measurements for your reference. Now, home blood pressure monitoring cannot assess the night blood pressure. I told you night blood pressure is very, very important, and the BP behavior during his daily routine work, at his office, in his work spot. We may not know how the blood pressure. We just take the tip of the iceberg by checking once the clinic blood pressure monitoring. Now we have the ABPM device available freely in India, and you can definitely use it, which I am using in my practice. And it gives information about the BP activities during the daily routine activities and during the sleep. The indications for ABPM is, one, I said the white coat hypertension. Other one is the masked hypertension. I told the definition. It's also called white coat normotension. Resistant hypertension, sometimes you keep adding drugs, the BP will never come down. We'll have a slight discussion on how to treat this resistant hypertension. We have people with episodic hypertension. People come with high blood pressure, then BP becomes normal, as in pheochromocytoma, anxiety. Pseudohypertension, when the vessel wall is thick, then the BP becomes very high. And I told you the person with the autonomic dysfunction, the diabetics, the patient has got a nocturnal hypertension as it occurs in the sleep apnea and diabetics. And once you are given a therapy, you tie this ABPM. We know how the patients behave with the BP drugs, and any hypotension occurring in the work spot or the night time with the BP drugs, that means you are given excess drugs. Pregnancy hypertension is very important to assess the blood pressure in a patient with a pregnancy, how they behave with their BP drugs. Renal hypertension is very, very important to have a ABPM. Children, always they do the assessment with the ABPM. Now the British Hypertension Society has said, virtually to diagnose everyone you suspect, you please always have the ABPM being done. This is one of my patients. As you could see, he has put on the one which measures the blood pressure, and the cuff is tied, and he has put on the shirt. You don't know anything, whatever he's wearing, you can just quote his work spot like that. So the ABPM offers the ability to collect the blood pressure readings over several times across the 24-hour period, rather than a single snapshot incorrect blood pressure reading in the clinic. Now, when you do the ABPM, the machine has to be set to take 14 BP readings in the daytime and 7 BP readings in the nighttime. But any number of times this can be set, but the minimum requirement is 14 in the daytime and 7 in the nighttime. I'll show you some of the graphs, what I have taken in my hospital. This is an unrecorded ABPM chart. The white lines, white paper says the daytime, and the black one is the nighttime. See now this patient, the daytime, nighttime, again the daytime. Now he has tied up the ABPM at 12 noon. Now 10 o'clock, 6 o'clock, and again we remove it at next day 12 o'clock. 24 hours ambulatory blood pressure monitoring. Look at the blood pressure. In the daytime, it is 135 by 85. That's the normal of the ABPM. It dips down to 120 by 70. This is normal. We have to dip in blood pressure. See, 15 millimeters systolic and 15 millimeters diastolic should dip in the night. At least over 10% of the blood pressure in the daytime should dip in the night. I tell you why the BP should dip in the night, and again the daytime it goes back. See, that's a profile. This is called the circadian rhythm. This is how the blood pressure behaves in every human being. If you have an abnormal pattern of this dipping, that means you are going for problems. Very, very important. Look at the graph, what I have now done in my patient. They had a blood pressure of 130 by 80 in daytime. Nighttime, the BP has nicely come down by 110 by 70. And as you could see here, it's got a perfect normal dipping. So this is a guy, that means he is doing very well with my therapy, or as such, he doesn't require any treatment. Now look at this patient. He appears normal 120 by 80 in daytime, but what happens to the night time? The BP has not gone down. So he's a non-dipper. Though the BP appears normal here, he doesn't dip the blood pressure what he has in the daytime. And again, the next day morning, the BP goes to 140 by 85. These are the guys, unstable people. We have to really watch them because they are the people going for problems. This is called the non-dipper state. Now, the dipper classification, we have 4 dipping categories. One is the dipper state. The blood pressure of the daytime should dip at least by 10 to 20% in the night. So that's actually a very good sign. That means you are dipping. That means you've got a very healthy vascular system. But some people don't dip in the night. Suppose if the dipping is only less than 10%, is a very bad sign. Sometimes instead of dipping, the nighttime blood pressure goes above the daytime blood pressure. It's called reverse dipping, or they are called the risers, nocturnal risers. Very dangerous signal again, because they are the people who go for again multiple problems. Some people you try to give many drugs, and the BP goes down more than by 20% of the daytime blood pressure in the night, then they are called extreme dipper state. So except the dipper status, all the other states are not good for the health of the patient. Why the causes of dipping the patient? Because there is a central sympathetic outflow is decreased in the night, and there's a decreased stress hormones in the night, and the muscles are relaxed, you're sleeping, there's a decreased baroreflex, and there's increased natriuresis. There are certain drugs which increases the natriuresis in the night, and you have to wonder why the BP should dip in the night. Very important question, because all the end organs take a perfect rest under low stress. It relieves the BP load on the end organs. So the organs don't go for the damage, or the organs don't go for further stress. The rest is important to prevent the target organ damage. So the nighttime dipping is an important thing in a patient's primary hypertension. Now look at the hypertension and diabetics. One of the study which is done in about 34,500 patients. Only 40% are dippers. Rest all have some form of 40 are non-dippers, 13 are reverse dippers, and 7% are reverse extreme dipping. So they are all very bad. As you could see here, the non-dipping is 40%. The nocturnal non-dipping is an independent risk factor for the end organ damage, which goes unidentified in office-based measurements. I tell you an example. Your blood pressure is normal for your patient all the time. See, you ask him to go for an echo. You ask him to go for a, say, urine analysis. The echographer says it's got left ventricular hypertrophy. Suppose the urine analysis says microalbuminuria. That means your BP treatment is not correct, because the blood pressure has already caused the patient to undergo left ventricular hypertrophy because of the non-dipping. So all the patients should undergo the simple test called ABPM to look for the non-dipping. Look at the nocturnal extreme dipping. Suppose you give a lot of drugs, over treatment leads to low perfusion to vital organs, which can also be diagnosed by ABPM. So the optimal dosage of the drugs should be there, especially in elderly guys. When you give too much of drugs, the BP will go down in the night. The risers or the nocturnal reverse dipping of the patients, the ABPM, the reverse dipping occurs in about 13%. The ABPM reverse dippers are mostly patients with CKD. Once they don't dip down, instead the nocturnal blood pressure shoots up more than the daytime blood pressure. We know these are the guys who are prone for CKD, or already they are in CKD. It predicts the CVD outcomes in patients with a kidney disease when this is added to the EGFR in CKD population. So this is the worst of all dipping status, the reverse dipping. So CKD and diabetics are the most common people with the non-dipping status. 67% of the CKD patients, they have a non-dipping pattern. 40% of diabetics have underlying CKD at the onset of diabetes. You remember, on the time of diagnosis itself, more than 1/3 of the diabetics have underlying CKD. Patients, when they do not achieve the desired target goal, even to the extent of less than 140 in the nighttime, have 12.9 times more risk of MI, 3.9 times increased risk of uremia, and about 3 times increased risk of death. So your bound duty to refer or to check your patients, their behavior of blood pressure by ambulatory blood pressure monitoring, to check the behavior of blood pressure in the nighttime, plus the 24 hours behavior of this blood pressure. Now, how to reduce the nocturnal blood pressure? You have to restrict the sodium to restore the normal dipping. And we can also use a thiazide diuretic or an AC inhibitor, or you can use a beautiful angiotensin receptor blocker like telmisartan, which is a potential therapeutic strategy to reduce the nocturnal hypertension. Now, the terminology called the chronotherapeutics. You inhibit the renin, which is very high in the night. Renin activity is very high in the night. That's why we give the ARBS or AC in the night time. So the increased nocturnal natriuresis by a bedtime administered thiazides or a renin-angiotensin system inhibitors like AC or ARBS suggests a potential mechanism of effective nocturnal BP reduction with a chronotherapeutic intervention to match the rhythms of disease. So please give the maximum dose of the blood pressure drugs. Suppose you're giving 3 drugs, a fixed dose, please give it at bedtime. If you're giving 3 drugs separately, give 2 drugs, at least the ACE or ARBS with the diuretic in the night time and the calcium channel blocker in the morning time. This is called the chronotherapeutics to adjust the circadian rhythm of the blood pressure. Now, this is a corresponding value of the clinic home blood pressure monitoring as well as the ABPM. Suppose your clinic blood pressure is 140/90, then the home blood pressure target is 135/85, and the ABPM 24 hours is 130/80. If you target 130/80 in your clinic, then the target remains home blood pressure is 130/80, and the ABPM target is 125/75. I think it's available in all the textbooks. You can take a measurement, you can keep it in your house, and tell your patients what's the target they should have when they measure the blood pressure in the house. Resistant hypertension, I think, is a big danger because you have resistant hypertension is a very big concern. It's defined as an elevated BP despite adding more than 3 drugs, among which one is the thiazide diuretic. Now, these are the causes of resistant hypertension. Suppose you are not taken an improper BP measurement. You're an obese guy, you're not taken a correct BP cuff, and sometimes the sister will come and say, sir, the person's BP is very, very high. Then we know he's an obese guy, you are not put on a correct BP cuff. So very important measurement is the BP cuff measurement should be proper. The guy who is taking excess sodium, again they have a resistant hypertension. The guy with the obstructive sleep apnea, again have the resistant hypertension. Some of the medications, the guys will be taking a lot of NSAIDs. NSAIDs, they retain the sodium, especially the diabetic people, the OAK, they will be keeping medicines like NSAID regularly in the night time. They will never, the blood pressure will be controlled because of the sodium retention by the NSAIDs. Illicit drugs, I told you, the cocaine, the amphetamines, methamphetamine, all cause hypertension. Sympathomimetics use, some of the people use cold tablets, and the over-the-counter pills again causes hypertension. Excess alcohol intake, I told you the binge alcohol again causes hypertension. Sometimes you miss the identifiable cause of hypertension. You miss the coarctation. You miss the abdominal aortoarteritis. You miss the renal artery stenosis. You miss the Pheochromocytoma. So again, then these are people who go for resistant hypertension. The 12% of the patients with the resistant hypertension are the big 3. After ruling out white coat effect, consider secondary causes again like the aldosteronism, obstructive sleep apnea, and renal artery stenosis. See, resistant hypertension, you please refer the patient to a specialist or please investigate like a Sherlock Holmes. What do you do when you suspect renal artery stenosis? You ask the patient, you suspect a bruit in the abdomen, the patient has got a renal artery stenosis. You ask the patient to go for MRI or a CT angio, or you can also do a renal Doppler if the person is competent. MRI and CT angio are equally accurate. MRI is used when the patient's got a very poor renal functions because we can't use CT angio. If both are contraindicated, renal Doppler, we can also do conventional angio to can help. Renal artery stenosis is of 2 types. One is the acquired, the fibromuscular dysplasia in the young, where the intervention, especially it is actually common in women, the revascularization or stenting of the vessel almost cures the patient 60 to 85%. But the older guys, above the age of 70, the atherosclerosis also sets in the renal arteries. They also go for renal artery stenosis. Here, the stenting does not help. Here, the patient has been treated with the ACE inhibitors or ARBS, and people have burned their hands by promising that by stenting the blood pressure will come down. It never come down. So don't treat atherosclerotic renal artery stenosis with the stenting. It's only for the congenital fibromuscular dysplasia to be treated with the stenting. So revascularization, as I told you, how effective in young, the women who has got renal artery stenosis. Obstructive sleep apnea, please consider the sleep study. Sleep study is available. I think some of the pharma companies are doing it on call, or you can do a sleep apnea clinical score, which we can download from the net. We can couple with the nighttime pulse oximetry. When the sleep study is not available, ask the wife to check the pulse oximetry in the night when the guy is sleeping at least 3-4 times. when the saturation goes down below 95. Now it's a corona time. I think don't do it now, probably after later, when the patient is obese guy, snoring, high BMI, all those guys have obstructive apnea. You only have to treat them with the CPAP. You give an apparatus. CPAP is very not very expensive nowadays. I think by 80,000 rupees, you get a nice CPAP. You apply at bedtime, which reduces the blood pressure. Tell the patient to reduce the weight and his BMI. Coming to the primary aldosteronism, this is a condition is very common in patients with a resistant hypertension, which we don't diagnose this because the adrenals go for diffuse hyperplasia. We can't image it and see whether the patient has got enlarged adrenals. Aldosterone is a sodium retaining hormone. There's a nice study from CMC Vellore in which they studied 100 primary hypertensives. Then they found out that at least 10 to 15% of them are suffer from primary hyperaldosteronism. That's why in resistant hypertension, you add a drug which blocks the aldosterone, the spironolactone. The fourth drug will be aldactone, the spironolactone. Once you add the drug, the BP comes down. So empirically, we think that when the patient is resistant, despite ruling out all the other possibilities, we suspect the primary hyperaldosteronism because these tests are very cumbersome because you have to stop the tablets, at least the BP medications, at least for a week's time. Then you have to check the plasma aldosterone, which is measured in nanograms, plasma renin activity in milligrams. Then to be done in the morning, at least 2 hours after waking in an upright position, you check the aldosterone renin ratio. When it is more than 30, it is diagnostic of primary hyperaldosteronism. We can also see the aldosterone level goes above 15 nanograms per deciliter. I think these are not necessary. Once you have suspected a resistant hypertension, when you have ruled out obstructive sleep apnea, renal artery stenosis, excess salt intake, all those things, then your diagnosis is that it is primary hyperaldosteronism. Please add spironolactone. The blood pressure will come down. Sometimes they can have adenoma which can secrete the aldosterone. Sometimes the CT and MRI will be helpful. Pheochromocytoma, in my practice of 40 years, I have found out about 5 cases of pheochromocytoma. I have actually found out in patients who come after 6 to 1 year with high blood pressure, shedding tears with anxiety. We tell them you are suffering from anxiety, but it is not true. Please see that the patient do not suffer from this. Very easy. You would only do the 24-hour urinary total metanephrin, not the VMA. Those days we do the vanillin mandelic acid. Now we do the 24 hours urinary metanephrin. We also do the plasma-free metanephrin. These two will confirm the diagnosis. We have to avoid some of the medications before doing this examination of the urine. CT or MRI again will tell you where exactly is the pheochromocytoma, the conventional sites. When you want to go for a nuclear scan, one of the excellent scan which will tell you the pheochromocytoma, ask the nuclear scan person to the MIBG scan. MIBG scan will tell you, because treating pheochromocytoma, you operate, the blood pressure disappears. Now we are coming to the main tract proper, the clinical manifestations of hypertension. It is usually a silent killer. Silent killer. My husband is normal, sir, nothing. The patient got the myocardial infarction, suddenly dies, stroke. History will be that he doesn't have any problems. So silent killer is the hypertension. Sometimes they can have occipital headaches, dizziness, fatigue. In severe hypertension, sometimes people can have epistaxis or a blurred vision, very dangerous signs in hypertensive emergencies. They can straight away manifest myocardial infarction, TIA, stroke, or sometimes they come with acute hypertension, manifesting both hypertensive emergency as well as the urgency. Why to treat hypertension? I think it's a baby question. It produces all complications. Left ventricular hypertrophy, myocardial infarction, coronary heart disease, hypertensive encephalopathy, hemorrhage in the brain, preeclampsia, eclampsia in pregnancy, stroke, CKD, ESRD, then go for a dialysis. It produces blindness, hypertensive retinopathy, aortic aneurysms. You can also go for a gangrene because the common cause of gangrene is diabetes followed by the hypertension. So one should really treat the hypertension, not the patient develop these complications. We always, in Indians, once we has gone for these complications, Then we start taking the diet, then we start taking the medications. There's no use because the vessel is already has lost its endothelium, vessels are already gone for damage. So it's very important that you have to measure the blood pressure. Tell the patient the importance of taking very simple medicines for blood pressure really avoids all the complications of hypertension. See, heart, it produces left ventricular hypertrophy, angina, myocardial infarction, heart failure, in brain, stroke or TIA, ESRD, CKD, peripheral vascular disease, retinopathy. In fact, if you treat a patient for hypertension, you have to monitor yearly with the echocardiogram. Your patient should not go for left ventricular hypertrophy. If the patient has got hypertension complications, the patient has got hypertension plus left ventricular hypertrophy, all the complications becomes fourfold. Stroke, myocardial infarction, PVD, everything becomes fourfold. So you have to choose drugs which regresses the left ventricular hypertrophy, not drugs just to reduce the blood pressure, but not to regress the LVH. We'll come to the particular aspect when we come to the treatment problem. So the LVH plus hypertension augments the hypertension complications by fourfold. CVD risk, again by hypertension, is continuous, consistent, independent of other risk factors. Uncontrolled hypertension is the #1 cause for myocardial infarction and stroke. Somebody asks you, what is the cause of myocardial infarction? First is age, above 65. Second is the uncontrolled hypertension. Then only other things comes. Now we have the triad of hypertension, dyslipidemia, and diabetes, smoking, overweight, all sedentary habits. They all lead to the cardiovascular complications. Now coming to the diagnosis of hypertension, lot of routine tests we have. We have to do these basic tests, very important. ECG, echo is a must. Urine analysis, urine albumin creatinine ratio, please ask the lab to do it. Or microalbuminuria. You have to check the blood glucose levels, serum potassium. Potassium, if it is very low, then one has to suspect secondary hypertension. So the serum potassium levels are very low in primary hyperaldosteronism. Creatinine levels in CKD, EGFR, which is estimated. Calcium in patients who have got a hyperparathyroidism, it is very high. Lipid profile, thyroid functions, both hypo and hyper can cause hypertension. And ultrasound kidneys, you should not miss the renal parenchymatous disease or renal artery stenosis, because that's the 80% cause for the secondary hypertension. More extensive testing, as I told you, what I showed you, the plasma, aldosterone levels, all the angio, MRA, all indicated when the BP is not controlled by your conventional testing and the treatment. Now, coming to the treatment overview, the goals of therapy, the following lines, we'll see the lifestyle modification, pharmacological treatment, algorithm for the treatment of hypertension, and what is the follow-up and monitoring of these patients. Now, the goals of therapy is that reduce the cardiac and renal morbidity and mortality, reduce the blood pressure less than 140/90 in a general population, and less than 130/80 millimeters in patients with diabetes and the CKD. And now I think this denominator has become constant for everyone. Treat the patients below 130/80. Below 130/80, that should be your goal in treatment of hypertension. How to treat these patients? Now we have the diet, the DASH diet, dietary approach to systemic hypertension. That's called the DASH diet. The patient has to definitely undergo exercise. Exercise really brings down the blood pressure. Lose weight. Weight loss again brings down the blood pressure. Reduce the salt and high fat diets again brings down the blood pressure. Avoid harmful habits like smoking and alcohol. So before pharmacological therapy, non-pharmacological treatment is very essential in the treatment of hypertension. So lose weight if you are overweight, increase physical activity, reduce salt intake, stop smoking, limit foods which are rich in fats and cholesterol. Please increase the consumption of fruits. The fruits consumption is one of the important things which helps the patient to control the blood pressure, and also take all colorful vegetables because they have a lot of antioxidants. Limit the alcohol intake less than 45 ml per day. See, when you have a weight reduction, there is a blood pressure reduction of 5 to 20 millimeters systolic by 10 kg weight loss. You have to tell the patient you reduce 10% of your body weight. So you can get a good reduction of blood pressure reduction and adapt the dietary advice in systemic hypertension eating plan. You can have the 8 to 14 millimeters reduction in the blood pressure. Sodium restriction, again 2 to 8 millimeters. Physical activity by walking every day. Just walk them. Ask them to walk 30 minutes a day. 150 minutes of walking every week is sufficient to bring down the blood pressure by 4 to 9 millimeters. And moderate alcohol consumption. Don't take alcohol. If you're really consuming, it should be less than 45 ml. The moderate alcohol consumption also causes little reduction in the 2 to 4. Once you start taking more than 45 ml, it's a J curve. The BP dips down, then again it starts going up. So don't allow the J curve to set in your patients with alcohol. I want to tell you something about the salt sensitivity, because people say, why do you want to reduce the salt? Salt sensitivity appears to be determined by genetic factors, race, ethnicity, age, gender, body mass index, and diet. Not everybody is sensitive to salt. Almost 40% are salt sensitive. You have 40% of hypertensives, mostly are salt sensitive. They have associated comorbidities like hypertension, diabetes, chronic kidney disease, and metabolic syndrome. They also play a big role in salt sensitive hypertension. How to know the person has got a salt sensitivity? One of the very recommended method is that to give 4 days of low sodium salt. See, less than 3 grams of salt per day, followed by high sodium diet. Say 12 grams of salt for next 4 days. So in a week, first 3 days, 3 grams. Next 4 days, you give 12 grams of salt. At the end of high sodium period, if the BP increases by at least 5% from the baseline, that means the person is be labeled as a salt sensitive. So the difference is that it's very difficult to do. So patients will say, my father is salt sensitive, my family is salt sensitive, genetic reasons behind it. I tell you why these people are salt sensitive, because of these transporters. There are 4 transporters in the renal. One is in the proximal tubules called the NHE3. This is the one powerful salt sensitivity producer. It's the overexpression. Whatever the sodium comes in the urine, it again takes it back to the system. So the the NH3 overexpression is seen in diabetics. There are now drugs to avoid this overexpression. Most of the angiotensin receptor blockers, they actually block the NH3 overexpression. There are other co-transporters like NAKCl co-transporter in the thick ascending loop, NaCl co-transporter in the ductal convoluted tubules. We also have the epithelial sodium collecting system in the collecting duct. In addition, we also have the SGLT2 and SGLT1. They also play a minor role in the sodium transport. So, but the NH3 overexpression is the one which is the powerful one, and it's the major sodium transporter. So, salt sensitive people has to be tackled with the drugs which acts on the NHE3 overexpression. Coming to the last session of my talk, the pharmacotherapy, I think one should really look into the therapy of these available drugs. We have the thiazide and thiazide-like diuretics. We have the AC inhibitors. We have the ARBs, the angiotensin receptor blockers. We have the calcium channel blockers. They are 2 groups. One is the dihydropyridine, and the other one is non-dihydropyridines. We have the beta blockers, we have the alpha blockers, we have the centrally acting drugs. We have the very important drug which is used in the resistant hypertension, the spironolactone, the mineralocorticoid receptor antagonist, which blocks the harmful effect of aldosterone. The other product, the eplerenone, is also used in hypertension, also in cardiac failure. Coming to the thiazides, we have the 3 drugs in our hand. One is the hydrochlorothiazide, which is conventional thiazide diuretic. Indapamide is again a thiazide-like diuretic. We have now the upcoming chlorthalidone, again is a thiazide diuretic. They act by decreasing the blood volume and the cardiac output. They decrease the peripheral resistance during the chronic therapy. And they are the drugs of choice in elderly hypertensives. All elderly guys to be started with the thiazide diuretic is the first line treatment in your, because this hypertension is volume dependent. It's not dependent on the renin. They have the volume dependent hypertension. So by giving thiazide diuretics, the blood pressure comes down. Very important is that these drugs cause hypokalemia, hyponatremia, hyperlipidemia. they are absolutely contraindicated in patients who got high uric acid. Don't use thiazide diuretics in patients who got a gout. Hyperglycemia is again one of the complications of the thiazide diuretics, and they are not safe in patients who got a creatinine which is more than normal and hepatic insufficiency. So we don't use it in patients more than 2 milligrams of creatinine. We don't use it in patients who got a child book classification of hepatic failure more than 2. Now look at the chlorthalidone versus the hydrochlorothiazide. This is the hydrochlorothiazide, this is chlorthalidone. Look at the chlorthalidone is very more effective than the hydrochlorothiazide in BP reduction. Look at the systolic blood pressure, 6 versus 11.14, and diastolic of 4 versus 7. So the chlorthalidone has proved much superior to hydrochlorothiazide, and now more and more the pharma companies are coming out with the combinations of chlorthalidone, small dose rather than the hydrochlorothiazide, because chlorthalidone has really proved that is much better, superior BP reducing drug than hydrochlorothiazide. Coming to the beta blockers, we have the atenolol, the time tested one, which has been really buried by the Dr. Nissen. He said this drug causes high diabetes and dyslipidemia, but people started using metoprolol, nebivolol, bisoprolol, and carvedilol. These are the molecules, the darling molecules of our Indian physicians. Most of them are cardioselective, some are non-cardioselective, like propranolol, which we use it in migraine. They decrease the heart rate and they decrease the cardiac output. They are the drugs of choice in patients with a coexistent coronary heart disease and heart failure. Don't use the beta blockers in primary uncomplicated hypertension. Please use it only in patients who have coexisting coronary artery disease. The side effects are lethargy, impotency, bradycardia, and some people have an adverse effect on the lipid profile, especially the drugs like atenolol causes very adverse lipid profile. So use some of the modern, the vasodilating beta blockers like nebivolol, carvedilol, and of course the bisoprolol is very popular among the cardiologists to treat the heart failure. This is only to treat hypertension with coronary artery disease, hypertension with heart failure. Coming to the calcium channel blockers, the dihydropyridine group, we have a number of drugs coming to the market. Amlodipine is a time-tested molecule which have a lot of evidences available in about more than 250 countries in the world. And nifedipine almost given up for the treatment of hypertension because it causes reflex tachycardia. We have the preparation which is sustained, which is used in patients with pregnancy. We have the modern cilnidipine which is coming up, and we have the benidipine. We have also the acilnidipine. Now we have another drug called efonidipine. I think more of these Korean molecules and the Japanese molecules are coming back with not much evidence. We have some evidence with the cilnidipine. These molecules they block the entry of calcium through these calcium channels, the L channels, N channels, and T channels. The L channels are present in the blood vessels. The N channels are present in the nerve endings. The T channels are present in the tissues of the adrenal medulla. As you could see, when they block the L, they dilate the blood vessels. When they block the N, the sympathetic activation is blocked. When they act on the tissues, it blocks the aldosterone. So a drug which really acts on these systems by all the 3 ways or by at least 2 ways is more effective than a drug which acts on a single way. Amlodipine acts only on the L channels. They cause vasodilatation, they reduce peripheral resistance. They are the drugs of choice in elderly hypertensives. One is the diuretic, thiazide, other one is the calcium channel blockers. And those patients with the asthma, this is the drug of choice. And patients with the post-MI angina who cannot tolerate the beta blockers, we can also give the calcium channel blockers. They have a neutral effect on the glucose and lipid levels. That's a good news. But the side effect is the pedal edema. About 30% of people on amlodipine will develop pedal edema. Probably it's not seen with the calcium channel blockers. Now we have the calcium channel blockers with the non-dihydropyridine group. It's not very much used in hypertension by Indian practitioners. Verapamil and diltiazem. They are also available in the sustained release preparation. They are again useful in the treatment of hypertension and angina. Their treatment of atrial arrhythmias can be done with these drugs. They are very mild antiarrhythmic drugs. They also control the ventricular rate in atrial fibrillation. So you can see the prescriptions of diltiazem along with the digoxin in patients with the atrial fibrillation. But now this is only used to treat the supraventricular tachycardia or ANVR, the atrial nodal reentrant tachycardias. And the common practice abroad is that these drugs are combined with the calcium channel blocks of DHP group, amlodipine plus diltiazem, amlodipine with. Normally, we don't combine drugs within the group, but there is an exception where the CCBs of different groups, both NDHP and DHP groups, can be combined together. We have a nice trial with the verapamil, the inverse trial which used the verapamil SR and the trandolapiril, which showed a decreased 3-point MACE. Somehow the molecule is not popular. Almost verapamil SR is being taken away in many of the countries, including US. Coming to the AC inhibitors, important drugs, the ramipril, lisinopril, enalapril is the darling molecule of the general practitioners, perindopril. They inhibit the ACE and formation of angiotensin II and they block its effects. It's a drugs of choice in coexistent diabetes mellitus and heart failure and peripheral arterial disease. Side effects is that almost 30% develop dry cough because of the bradykinin effect. They sometimes cause profound hypertension. I've seen one case of angioedema with the AC inhibitors. Very difficult. They don't respond to conventional anti-allergic drugs like your adrenaline or your drugs like Avil and things like that. Very difficult to treat. Remember the HOPE trial, which brought the ramipril to the limelight in the treatment of hypertension with the cardiovascular disease and to prevention of cardiovascular disease. Very important group is the angiotensin II receptor blockers. We have the losartan, telmisartan, azilsartan, olmesartan, valsartan. They block the angiotensin II receptors and they inhibit the effects of angiotensin II. They are the drugs of choice in patients with the coexisting diabetes mellitus and CKD. Very, very popular molecules are these ARBs, especially the telmisartan. The side effects is they are very safer than ACI. They don't produce the cough, which like AC inhibitors. And they are very also doesn't produce very severe hypertension like your AC inhibitors. Drugs of choice in the management of hypertension in India and again rest of the world. Alpha blockers, we have the prazosin, which is now used only in patients with the prostate hypertrophy. It has no CV benefit and it also can cause postural hypertension. Not very popular. It's actually alpha blockers are added as a fourth line drug in the management of hypertension. Steadily acting drugs, we have the Clonidine in Indian market. Guanfacine is not available. We have the alpha methyl dopa. We have moxonidine in Indian market. We don't have rilmenidine. These drugs are used by the nephrologist, by the resistant hypertension, CKD and ESRD. And of course, the alpha methyl dopa is the darling in pregnancy. This is the only drug which is available to treat the pregnancy patients. So these drugs are only used as the last line drugs when the other available better drugs fail. Now look at the Clonidine, which is used apart from hypertension in dysmenorrhea, hypertensive crisis, the tardive dyskinesia, the Tourette syndrome, menopausal heart flushes, alcohol opiate withdrawal, smoking cessation therapy, autism, hyperactive attention disorder, migraine prophylaxis, and anxiety. I think more than hypertension, these drugs are now becoming popular in some of the very rare syndromes where you can try this molecule in your general practice. Hypertension flow chart, very, very important slide. I'm going to show you how do you proceed with your patient with hypertension. Now, patients with hypertension coming below the age of 55, 50, 40, they are dependent on renin. Their primary hypertension is a hypereninemic hypertension. So you have to block the renin in those patients. So you start a patient with either AC inhibitors or ARBs. But always the choice for the practitioners is for everyone, including me, is to start a patient on ARBs as a first line. You target the blood pressure of 130/80. Say after 4 weeks, the BP has not come down. Then you add ARBs with the CCB. The well-known CCB is amlodipine. We can also now add cilnidipine as a second line. Now, second line drug, they have added. Now, after 3 weeks, the BP has been checked. the BP is not on, again target, then you can add ACD, the ARBS, calcium channel blockers, and the thiazide. This is actually one of the very powerful combination. Almost 70% of the hypertension will come down by this management of the ACD, the ARBS, amlodipine or cilnidipine, plus a thiazide diuretic. Suppose the patient still the BP is not on goal after 3 weeks, then you can add an alpha blocker as a fourth line. The only available is the prazosin. Doxazosine is out of the market. Again, the patient does not show, then we know the patient has got a resistant hypertension. Quite possibly the patient is suffering from primary hyperaldosteronism. So now the choice of drugs becomes the ARBS, CCB, thiazide diuretics, and the spironolactone. Empirically, because these patients respond to spironolactone in resistant hypertension. Now, I never mentioned the beta blockers. The beta blockers again comes only on compelling indication. These patients develop ischemic heart disease, they develop myocardial infarction, post-MI angina, then the beta blockers come into the group below the 55. This is the flow chart of patients for the age below 55. The patient is above the age of 55. Elderly guys, the blood pressure is not renin dependent, it is volume dependent. So you start the patient either with the calcium channel blocker of the DHP group, amlodipine, or you start the patient with the thiazides as a first line drug. Check the BP after 3 weeks. The BP has not come down. Then you can add a CCB with the ARBS or ARBS with the thiazide. Any one combination. This is a better combination than this, but economically the viability is ARB thiazide. So any two combinations you can add as a second line. After 3 weeks, the BP is not still come down. Then you come to the combination of ARB, CCB plus thiazide as the third line drug. So fourth line again comes to the same as the ARB, CCB, thiazide is the alpha blocker, because most of the patients may have an enlarged prostate. The drug will act as a fourth line drug. Fifth line is again the resistant hypertension, where we are bound to add a spironolactone. So we add ARB, CCB, thiazide plus spironolactone. The blood pressure will come down. Most of the patients will be, by this time, would have developed some form of cardiac problems. So beta blockers on again compelling grounds, but most of the patients require at this age group because they would have developed. So most of them will be taking a combination of these drugs along with the beta blockers. So beta blockers, the therapy of hypertension doesn't stop with one drug. Almost the patients will be taking 3 to 4 drugs in the armamentarium. The target blood pressure should be achieved. You have to fix the target, 130/80. That target to be achieved by combination of drugs, and it is very important to prevent the target organ damage. This is the nice guideline by the British Hypertensive Society. The same nice guidelines as they say the ACD, the AC inhibitors or ARBS, calcium channel blockers or diuretics, which replaces the old ABCD after the accomplished trial. As you could see, the age less than 55 years use either one of the ACE or AC intolerant ARBS, and the age above 55, they straight away say not even diuretic, they start only with the calcium channel blockers, then come to A plus C, then they come to A plus thiazide diuretics plus CCB. If they're resistant, then again you try to add alpha blockers or the beta blockers as per the step 4 treatment. So now the whole armamentarium of treatment is ACD, ARBS, calcium channel blockers, and thiazide diuretics. Now, some of the drugs used in pregnancy use nifedipine, labetalol, hydrolysine, beta blockers, methyldopa, and prazosin. These are the only drugs which are used in pregnancy. We can't use the other drugs. Suppose the patient has got a coronary artery disease, beta blockers, AC inhibitors, or ARBS, calcium channel blockers. And in congestive heart failure, we have to use AC inhibitors, ARBS, beta blockers, and of course the newer molecule called the RNA, which is a molecule which is now for the Indian market more than 2 years, very useful in congestive heart failure. In patients with the bronchial asthma, start with the CCB. Patients who are diabetics, please start with the ACI or ARBS. Elderly guys, always calcium channel blockers or thiazide diuretics, including indapamide or and ARBS. Very elderly, there's a nice trial called Harvard trial, which is used an AC inhibitor called perindopril and a thiazide-like diuretic called indapamide. So now you understand the flow pattern of treatment of the available pharmacotherapy. Remember, first diagnose hypertension, primary or secondary. When you come to primary, then you have to see the age of the patient, 55, above 55, renin or volume, then start adding the drugs one by one. But your bound duty, the patient has got a resistant hypertension, to look into all causes of resistant hypertension, salt sensitivity, obstructive sleep apnea, or the patient is overeating and so lifestyle modifications comes before pharmacotherapy. Then the pharmacotherapy plays a big role in the treatment of hypertension. Now ARBS, a few slides about the ARBS, they rule the hypertensive market, not only in India, but also in abroad. ARBS are the most prescribed antihypertensive drug class in India and across the entire globe. Among the ARBS, telmisartan is the top selling molecule in India and the rest of the world. Why? Because with telmisartan use, most of the physicians reported adverse events and discontinuation rates less than 1% in the clinical practice. So the patient would have come from a distant place to you for consultation. You prescribe a CCB or a AC inhibitor, they come with the pedal edema or cough. You may not know what is the cause for the pedal edema, not for the cause of cough. But when you prescribe an ARBS, you're comfortable. The drug acts very well and they don't have any side effects. That's why the drug is so popular in India. There are two nice trials with the telmisartan. One is the on-target study, other one is the transcend study. The on-target study demonstrated the telmisartan has the ability to reduce the CV morbidity in patients who manifest atherosclerotic CVD. And the telmisartan treatment, the transcend trial, was associated with a significant reduction in the number of myocardial infarction and stroke events in hypertension. That's beautiful, two big trials, which is the real background for the telmisartan prescriptions. That's the stroke reduction with the telmisartan. One is the transcend and the other one is the on-target, which has really shown a huge reduction in the incidence of stroke. Here, the transcend also proved it is effective in preventing the myocardial infarction. The pharmacology, the 99% eliminations by the liver. So it's a very, very safe drug in patients with a CKD. So the unique characteristics of the patients, the drug like telmisartan as the preferred ARB choice in combination therapy of BP lowering agents, especially the CCB in the elderly, diabetics, and diabetic patients with nephropathy. You do not get worried about the creatinine levels because the drug has no elimination through kidney. Very safe drug in patients with the CKD. And the majority of the surveyed physicians, more than about 87%, supported the use of telmisartan in hypertension patients owing to the pleiotropic effects on PPR gamma receptors. I tell you what is the PPR gamma receptors. These receptors are gene-oriented receptors. They actually, when it is being stimulated, it actually improves the surface GLUT4 receptors. So the entry of glucose into the cells is being improved. It also improves the lipid dissociation by improving the fat transfer protein in the cell wall. So both are improved by the PPR gamma receptor agonist activity. So they help in patients with the diabetes, reducing the insulin resistance, and as well as patients with the glucose intolerance. So there's a two beautiful pleiotropic effect of telmisartan. See, the PPR gamma agonist activity improves the insulin sensitivity by improving the DPP, the GLUT4 activity, suppresses the atherogenesis by the plasma, the transfer protein expression, reduces both the glucose as well as the triglycerides. It also improves the endothelial dysfunction. So, very important effect apart from hypertension, safe drug, 24 hours acting, once a day dose. What else you require? So the data says telmisartan was the preferred 24-hour BP control, including nocturnal dipping and morning BP surge, and prevention of CB morbidity and mortality by almost 2/3 of physicians in India, 76 and 79%. With the highest affinity for the angiotensin II type 1 receptor, telmisartan provides long-lasting antihypertensive effects compared with the other ARBs. I think This is one of the beautiful, so many sartans are coming to the market, but nothing to displace the well-established telmisartan in your practice. The minute you diagnose blood pressure, we doctors write the telmisartan prescriptions. The fixed drug combination with the telmisartan, the triple drug fixed dose combination with the therapy of telmisartan, amlodipine with the chlorthalidone or hydrochlorothiazide was found to be an effective, safe, and convenient once a day at bedtime therapy, chronotherapy approach in achieving the desired BP goal in uncontrolled hypertension. These three drugs acts in almost 70% of the tough hypertensives, and very smoothly the blood pressure comes down, and we need not get worried. I think a lot of pharma companies are now coming with the triple drug combinations, with the fixed drug combinations. They do really wonders. I think the newer therapies in hypertension, one is the renal denervation. You go and remove all the sympathetic chain over the renal arteries, by which the blood pressure comes down. It's getting popular now. And we also stimulate the carotid baroreceptor stimulation by a small battery like your pacemaker. Again, in severe tough hypertension, these two therapies work. I think I've come to the end of the road by telling you all about how to diagnose hypertension, how do you miss the white coat effect hypertension, mass hypertension, home blood pressure monitoring, ambulatory blood pressure monitoring, then coming to resistant hypertension, then primary hypertension, non-pharmacological treatment, then pharmacological treatment. Now the last slide is acute hypertension. It's a big emergency. It's a common, and it can be divided into hypertensive urgency or hypertensive emergency, in which the blood pressure is greater than 180 by 120. When it is without organ damage, it's called urgency. With organ damage, when they come with a stroke or hemorrhage, it's called hypertensive emergency. It's a very, very different kettle of fish. The BP guidelines, treatment of thing varies and being discussed in many forums. It takes a huge number of hours to discuss. So if the company allows me next time, I think I can talk about the management will be discussed in the next module of management of acute hypertension. These are the BP thresholds. See, the BP goals. Look at the BP goals. Everybody is 130 by 80. Clinical CVD, no clinical CVD. Older patients, diabetes mellitus, chronic kidney disease, chronic disease after transplantation, heart failure, stable heart disease, ischemic, secondary stroke prevention, secondary lacunar stroke prevention, peripheral artery disease, the whole set of things except the secondary stroke prevention. I think the BP goal, the target is less than 130 by 80. See that after the sprint, the whole scenario is changing. When the patient, old guys, they withstand the blood pressure to this level. It is ideal blood pressure to keep in your patients with the available advice on them with the non-pharmacological and pharmacological measure, the therapy. The take-home message is the hypertension is a major cause of morbidity, mortality, needs to be treated. Extremely common condition, but it is still underdiagnosed and under-treated. Hypertension is easy to diagnose and easy to treat. Please don't forget secondary and resistant hypertension. Aim of the management is to save the target organ from the deleterious effect. Lifestyle modification should be always be encouraged in all hypertensive patients. This is my final slide, and I here welcome any questions from the audience on their experience on hypertension. They have any small doubts. I have some questions to ask you, whether you really followed the presentation. I'll put on the slides. You can try to answer. The question number 1 is lifestyle intervention for management of hypertension includes all the following except regular aerobic activity 30 minutes per day, salt intake less than 6 grams, maintaining BMI more than 25, diet rich in fruits, vegetables, and restricted content of saturated fats, and moderation of alcohol consumption, which is false here. I'll tell you the answer also. The answer is that you have maintained the BMI less than 24. But as per the Indian standards, it is less than 23. 19 to 23 is normal BMI. 24 to 29 is overweight. And 30 to 32 is obesity. And more than 32 is called morbid obesity. Question number 2 is, Hypertension management is helpful in the prevention of all except coronary heart disease, heart failure, chronic kidney disease, DVT, and cerebrovascular disease. I think the answer is very straight away easier. It is not helpful in deep DVT. Isolated systolic hypertension is common in young, elderly, pregnancy, blacks. Where is it common? It's common in elderly people. Antihypertensive agent recommended for the protection of cardiovascular disease is calcium channel blockers, diuretics, AC inhibitors, ARBs, alpha antagonists, cellular stimulatory drugs. The answer is AC or ARBs. They are the drugs who really regress the left ventricular hypertrophy. If we really prescribe ARBs, the patient with the hypertension, the LVH regresses. ARBs play a renal protective role through all except they decrease the proteinuria, they decrease the intraglomerular pressure, they prevent the endothelial dysfunction. Do they inhibit the conversion of angiotensin 1 into angiotensin 2? They block the angiotensin mediated renal demodeling. I think the answer is D, because this is being done by AC inhibitors, not by ARBs. Which of the following is the side effect of AC inhibitors? Hyperkalemia, hypercalcemia, hyperglycemia, hypertension, hypermagnesemia, hyperkalemia. The people who are taking AC inhibitors, when they say they have a little tiredness, muscle weakness, you have to suspect hyperkalemia. Very important. Calcium channel blockers causes all except pedal edema, flushing, hyperkalemia, headache. It doesn't cause hyperkalemia. That's one of the good effects of calcium channel blockers. Safest drug for hypertension in pregnancy is AC inhibitors, angiotensin receptor blockers, diuretic, methyl dopa. I think a very easy question. It's only methyl dopa which is indicated in pregnancy. I told you 5 to 6 drugs which can be used in pregnancy. The first line antihypertensive in diabetic patient is the diuretic, AC inhibitors, ARBs, beta blockers or calcium channel blockers. It's always the AC inhibitors and the ARBs. The last question is that which of the following antihypertensive agent is relatively contraindicated in severe the New York Heart Association class 4 congestive heart failure? AC inhibitors, angiotensin receptor blockers, beta blockers, and diuretics. Normally, we also give beta blockers in heart failure, but not in the severe heart failure. We would really stabilize the patient before we add the beta blockers. They are the sheet anchors in heart failure, but not in acute heart failure. We have to stabilize the patient before we start the beta blockers. I think that's the end of my slide. I am bound to here to share with you a few minutes of any of your questions. Hope I made the entire presentation of hypertension in a matter of how much time? I think really took 1 hour 18 minutes. I think it's a big time. I overshoot the time.
Thank you so much, sir. It was really enlightening to know all about hypertension, and our audience is also very excited. And that is the reason we have a number of questions. So, sir, one of the common questions that is coming is management.
I'll come back to the screen.
Sir, can you hear me? Yeah. So, one of the common questions that is coming up is management of hypertension in pregnancy. That is asked by many doctors. So, can you please once again enlighten us that how do we manage hypertension in pregnancy?
The pregnancy hypertension, we can't use AC inhibitors, the angiotensin receptor blockers. We can use nifedipine, we can use labetalol, but the sheet anchor is alpha methyl dopa. We can use the beta blockers like the time-tested atenolol. We can also use hydralazine, which is usually used in emergencies. And now we also use the prazosin. These are the 5 drugs which are used in pregnancy hypertension. We don't use other drugs in class of drugs in pregnancy.
Right, sir. Sir, thank you so much for that. Another common question that is coming up, Dr. Raghunath from Bangalore has asked this question, that what is the preferable time of administration of antihypertensive drugs? Is it bedtime or in the morning?
That's why I told you the chronotherapy, the circadian rhythm, the blood pressure dips in the night. So always add the maximum number of the maximum drugs in the bedtime. so that the blood pressure dips in the night. The blood pressure should dip from the daytime blood pressure at least by 10 to 15%, so that the target organs takes a big rest. So the chronotherapeutics, the circadian rhythm is followed once you add the drugs at bedtime. If you're adding a fixed drug combination, please add it at bedtime. If you're adding 3 drugs, the 2 drugs to be added in the bedtime and 1 drug to be added in the morning.
Right, sir. So that also brings us to the question, and one of the doctors have asked this question, that many people work in shifts. So as we see a dip in the blood pressure in night, would a person who's working in the night see a diurnal dip in blood pressure?
I think it's a very, very important, nice question. I've seen an effect called evening surge of blood pressure. The circadian rhythm changes in people who got 3 shifts. That's why the ABPM helps you, where exactly the blood pressure dips and where exactly. They are called evening dipping. So nocturnal dipping, the blood pressure dip in the night. So what we try to add those patients, the shift time, the time when they go to the bed, that time we add the drug. That is the bedtime dosing. The time they go to bed is called the bedtime dosing. So the whole event of try to avoid these sort of shifting systems. If you're still on the shift system, best time to take the BP drugs is the time when you go to bed.
Right, sir. So that would be daytime in case of a night worker. Right. So Dr. Usha HV from Bangalore has asked that clinically we give telmisartan 40 milligram. How much blood pressure do we expect it to reduce on a systolic and diastolic basis?
See, you are adding a very small dose of telmisartan. Normally we start with 40 milligrams. We see the response in about 3 weeks' time. When the BP doesn't dip, the systolic blood pressure, the maximum capacity of only isolated drug by telmisartan is only about 7 to 10 millimeters. It cannot reduce more than that. That's why people who got a blood pressure more than 140 by 90 is considered as stage 2 hypertension. Please start with the 2 drugs. Please start the patient with the telmisartan plus with the calcium channel blocker, so that you get the blood pressure less than 130 by 80. Gone are the days we start with the monotherapy, then you start the patient with the gone are the days where you start a patient with a single drug, then add 2 drugs. The step dose therapy is gone. So I told you 70% of the Indian hypertensives are in stage 2 hypertension. This is our experience. So we normally start most of the diabetics. All Indian patients are diabetics, most of them. So we always start them with the very nice combination of telmisartan plus the calcium channel blocker.
Sir, Dr. Gupta asks a very important question that we are familiar that says the COVID virus enters the cell through the ACE receptors. So if a patient is on ARB or ACE inhibitors, and we are currently in the pandemic state, so what should be done? Should they be withdrawn or should they be continued?
There's a very important being discussed by very many specialists from very many countries, whether to withhold these AC inhibitors or ARBs. But all the guidelines have come out with a very clear cheat. If the patient's primarily controlled with the drug, where what he is taking AC or ARBs, there's no need to stop it. We can continue the drugs, except in patients with diabetics, we stop the SGLT2 inhibitors, and sometimes we also stop metformin. But BP drugs, because he said the AC2 receptors exposes the AC2 receptors number in patients who are taking ARBs or AC inhibitors, and there's a theoretical possibility of this virus gets more receptors. It's true, but all the guidelines, after very heated arguments, discussions, by stopping that, the patient will go for more complications than continuing the drug. So there's no need to stop worrying about that theoretical aspect of AC2 involvement of the cells by the coronavirus in people who are taking the ARBs or AC inhibitors.
Right, so that was a huge concern when we started with the pandemic, but as time is evolving, I think we are getting more clarity day by day. So Dr. A.I. Raju asks that what is the hypertensive drug of choice in a type 2 elderly diabetic patient who also has edema?
Who also has edema?
Yes, sir.
We don't know what's the cause of edema. Edema is due to cardiac failure or liver problem or a kidney failure, or if the patient is taking a calcium channel blocker like amlodipine, or the patient is taking any pioglitazone, or the fellow is taking a NSAID. So first, please find out the cause for the edema before we prescribe. Probably the situation, the patient can be started with a diuretic because he is elderly, volume dependent, so the edema also will disappear. But please see that a diabetic person gets edema. It is the drugs which causes edema is one is the pioglitazone, other one is the pregabalin. They cause edema. Number two is the NSAID is what the people take for osteoarthritis can cause edema. These people are prone for the fatty liver and chronic liver disease. They can cause edema. They can have a CKD. They can cause edema. The patient may be in a mild heart failure. So number of causes for edema sake. So I understand the question, the doctor's question, whether the CCB will induce or aggravate the edema. So before put the patient on CCBs, please find out the cause for edema in this patient.
Right, sir. So very common question that we clinically need to differentiate, and Dr. Bhaskar from Bomraspet has asked this question, that how do we clinically differentiate between dyspepsia or gastritis versus a MI?
Diabetics is a big problem. The diabetics with the inferior wall MI will classically come with like a dyspepsia. So a person who is diabetic has a problem is that please observe him at least for 12 hours. We have the we have to observe him for 12 hours to 24 hours. Check the troponin I at least 2 times. Check the ECG at least 3 times before we rule out that patient's symptom is not due to the gastritis, is due to the inferior wall myocardial infarction. Gallbladder, stomach, and heart, they all behave the same. So very important is the observation. Those patients must tell them, please be here in the hospital for 24 hours before we rule out that you don't suffer from ischemic heart disease rather than the very simple chronic gastritis. Of course, as you said, the GERD, again, very classically affects the patients with the diabetes because the sphincter laxity occurs. They also have the nocturnal cough. So a diabetic person comes with a nocturnal cough. We know it's not due to asthma, it's due to the GERD.
Right, sir. So we have a question from UK as well. And Dr. V. Chandran has asked this question. Any role of minoxidil in controlling resistant blood pressure?
Minoxidil was once used, even right now it's being recommended. Now we need to use it only for growing mush and the bald heads. Resistant hypertension, minoxidil is being there. I didn't mention it because it's a drug even the super specialists don't use. But minoxidil is in the book that it is useful in treating. It's a vasodilator. It's a vasodilator being used in patients who also got CKD. We can use minoxidil. That's a very, very nice question. I think it's a good question. Available in India as a topical solution, 1% for the dermatologist, but I don't think oral tablet is available for prescription for the hypertension.
Sir, Dr. Rajiv from Kozhikode has asked this question, that there's a patient who's having hypertension and he's already on a combination therapy of ARB and calcium channel blocker. Still, his blood pressure is not controlled and the heart rate is above 80. Can we add a beta blocker if there is no
guidance? Suppose the patient has got you added 2 drugs, or even I can say you added 3 drugs, then the heart rate, if the heart rate is normal, add alpha blocker. If the heart rate is high, you can add a beta blocker. That's what the British Hypertension Society has given a lenience. As a 4th line, look at the heart rate. The heart rate is very high, add a beta blocker. Heart rate is normal, you can add the 4th drug as alpha blocker. Definitely, yes.
Right, sir. And I think we are done with the questions. And so on behalf of MacLeod's, I thank you for the wonderful presentation, and I would like to hand over to Mr. Jagdish Joshi.
It was really a nice session, and everything about A to Z as far as hypertension is concerned. Dr. Lakshmanan has taken everything is concerned. Even a layman like me has understood a lot about the hypertension is concerned. I definitely expect all the audience must have understood a lot as far as hypertension is concerned. Thank you so much, sir, for your, it was really 1.5 hour session. Okay, so everything regarding the hypertension is clear. I hope all the audience must have understood, enjoyed the session. Once again, thank you so much, sir, taking your valuable time and enlightening everybody as far as hypertension is concerned. On behalf of Macleod, we thank you once again, sir.
Thank you. Thank you. Thank you.
My pleasure.
Thank you. Thank you.
Okay.